Okay, everyone, welcome to Grow My Dental Practice webinar and podcast. I've actually written this down because every week I forget to mention all of these things and just get chatting. Tuesday night here in Australia and 4 a.m. in Kentucky, USA, where we have Professor Tom Larkin joining us. Welcome, Tom.
Thank you very much.
No, thank you. I know that the two gentlemen I've got here can definitely draw a crowd. And so this podcast/webinar series, we haven't decided what it is. I think it's a pop-up something. I don't know. It's presented by Seven Figure Hygiene and the Larkin Protocol. So I'm really pleased to have you here, Tom. And we're striving to bring medicine and dentistry back together, as well as reignite the passion and skyrocket production in dental hygiene departments. I'm your host, Sue Rusalem. And this evening, we have Michael Wong from BES, and we have Dr. Jason Pang from Cosmic Smiles and Laser Dentistry. Welcome, Dr. Pang.
Hi, Sue. Good evening.
I'm glad you're on. I've got lots of questions to ask you. And welcome, Michael. I also want to welcome the Larkin Fab Five, the first 5 people in Australia to bring the Larkin Protocol into their practice. They always pop in and out, and I genuinely appreciate everything that you've done for our program and the dentists in Australia and around the world. And to the Larkin Protocol certified clients, and in particular, one of our crazy hygienists, Katie Phillips. She's here today, but she's feeding her pets as she listens to us. So today we're going to talk about ozonated water and the use of ozonated water in the dental setting. So we'll move over to Dr. Pang. Jason, I probably should give you more of a welcome than that with all of your credentials. I feel that we know you very well now. You work in Northern Sydney at Cosmic Smiles and Laser Dentistry, and you're a very early adopter of all things gizmo and really cool. And so I'll hand over to you and you can let us know what you've got to share with us tonight.
Thank you, Sue. Well, I thought I'd just follow on from what you were saying about biofilm. And the thing about biofilm is that it's a problem universally around the world. It is something, whenever you have a liquid solid interface, you're going to have a biofilm problem. So we're talking about industrial cleaning, we're talking about restaurants, ice and water supply, clean environments, we're talking healthcare. So anytime you would be intubated or you have a catheter put in, care, childcare, these are all industries that can benefit from having biofilm removal. So even though I'm going to be talking about the dental industry, this is a problem that really everybody has to deal with. So yes, ozone in the dental suite. So here I have a picture of when I first got my practice, and this is before I really did anything to the practice, and it's a sterilization area and the lab. And one of the problems that we had is that we always had a really bad smell coming from both of those areas. And we couldn't really ever figure it out. And so we tried flushing with various products, and then we decided that we would look at, so we looked at various ozone products, and as Michael said, there's lots of different ones. We looked at one of the catalytic versions, which generated it from electricity and bubbled it, and that wasn't so effective. But this here is one of the early biotech units. We got this in 2011. This is actually one of the very first products, which is an electrolytic product. It generates 1 to 3 parts per million. And, it was designed to be used for hand washing, for washing foods. You could drink it as well, but it is antibacterial, antiviral, antifungal. It kills protozoa, it kills parasites. So it's a very, very nice product. And very soon after we started using this, the smell in the sterilization area and in the labs, that all went. We eventually upgraded this product, and this was originally supplied to us by Mint Devices, Tony Konevsky, who's on the call. Now, this is a very early implementation of a very effective method of generating ozone. So it took us a little while, but we eventually realized that there's more to it than just those two areas. We obviously have dental chairs and the dental unit water lines. So this is in 2012 when we decided to test the various chairs that I had. So I had 3 rooms. So you can see S1, surgery 1, there's some red bacteria there. We can see on these dipsticks, that's a measuring tool, it's called a dipstick. In surgery 2, there's more, and surgery 3, there's even more, compared with tap water on the lower right-hand side. So if we look at the chart and see where it lies, we can see that the red dots is somewhere in that range of maybe 1,000 to 10,000 colony forming units. The middle one more, and the upper right one, yeah, it's too many to count. So really, in terms of what's considered acceptable, probably there, where it's outlined in green, that's 100 colony forming units. 100 to 200 colony forming units would be what is considered acceptable. So I'm way over that, and that was a big shock, because I thought that I was doing the right thing. I was flushing lines with just normal water, but it wasn't until we developed the protocol and started to use the ozone that we happened to see improvement. And this is what happened. So you can see on the upper left-hand side, there's four dots there. So that's probably around 200 colony forming units. On the lower left-hand side, there's a little bit more, but that's in one of the chairs that we don't use as often, and probably didn't have a protocol in place to flush those lines pretty well. But on the lower right-hand side, you can see the ozone that's generated that has no colonies forming on that. So really, this is the difference, and this is what's very important. On the left-hand side, you have ozone, and when I use the ozone, basically there's no bacteria detectable. On the right-hand side, if you don't follow the protocol, if you don't rinse, you're going to have a high number of colony-forming units, way more than is what's considered acceptable. We'll talk about that soon. But these are the main things that we're trying to prevent when we clean our lines. We want to prevent Legionella, we want to prevent Mycobacterium species and Pseudomonas aeruginosa. These are all things that in aerosol form can be a problem, especially for the immunocompromised. And then there's Streptococcus, and there's other ones that we can reduce as well. But we certainly don't want to have this kind of a problem and expose immunocompromised patients to bacteria like this. So when I was doing this research and I was putting this together, this is what I found. This is a Perth hospital in Western Australia, and they had to shut down their hot water system because it was contaminated. And last year they had someone die because of a Legionella outbreak. So you absolutely do not want to be dental surgery that appears on the news because they gave their patient Legionella. And this is, very, in realistic terms, this is still happening. This is something that concerns all healthcare. So here's an old protocol, waterline protocol, where they recommend the colony, less than 200 colony forming units per mil. For the immunocompromised, around 500 for normal dental procedures. And so the guidelines say flush the lines in the morning for 2 minutes and then 30 seconds between patients, test every few months, and then if it's above that amount, you need to shock them. But look what happens when you don't shock them. On the upper left-hand side, you have what they call slime worms. These are basically buildup of the biofilm, and if you don't take care of that, what happens is they come out, especially when you take the hand pistols off. You can see all this stuff oozing out, and it's disgusting to see. And Prof. Larkin has showed before a really big slime worm, which is quite terrible to see. On the lower left-hand side, you can see how the planktonic bacteria, they adhere to a surface, and then they start to accumulate. They build up the biofilm. Before then, you have parts of the biofilm breaking away. So this are the international guidelines. So in the UK and EU, it's 100 coliforming units per mil, 200 in Australia, 500 in the US. So this is part of Laurie Walsh's presentation. He's one of the world's best researchers in terms of biofilm and water lines. If you do a search for water lines 2022, the PDF, you will find his presentation and some of these slides that I'm showing now. But this is a standardized modern form of that dipstick. And you can see on the top, 0 coliforming units in sterile water or in ozonated water. On the lower left-hand side, you have that 220 coliforming units in tap water, which is pretty normal. Water will have some bacteria in there. And then on that lower right-hand side, 350, which is above the recommendations, which come from either the HAMPs or the triple. So this is what we do in my practice. So on the left-hand side there, I have my 8-egg chair and the water line. So in the morning, we will flush the chair for 1 to 2 minutes. And then what happens is we leave the water in there for the rest of the day. Because as the ozone breaks down in the dental chair, it becomes virus-free, bacteria-free, fungus-free water. So that is perfectly suitable for use for the patients throughout the day. And then at night, what we do is we flush all the water out of the lines so that it's kept dry in the evening, so that if we don't come back the next day, if we have a long weekend, if we go on a holiday, we don't have to worry about any growth in the line. On the right-hand side is the airflow device. I'll show you that device soon, but that's one of the devices that we use for guided biofilm therapy to clean the patient's teeth. And so we will use 4 ppm ozone in both of these systems. And when you have foul water lines, that's when you need chemicals like the Alpron, Bilpron, BioClear, or peroxides, or ozone. So you can see if the treatment for fouled lines is ozone, if I'm using ozone on a daily basis, twice a day, you can see how I don't have a problem with biofilm in my lines. So that OH10 product is one of the first products that we started with. That's like a soda stream, it would bubble the ozone into the bottle with water. Next to it is a smaller device that generates ozone and continually bubbles it. But the thing to understand is that with both of these devices, you do not have an idea of what kind of concentration of ozone you're generating. These are not therapeutic products. I don't think they're TGA approved, so you don't know what kind of contaminants that they have in there. These are not products that are suitable in dental surgery. This is, maybe you could use it at home or something like that, but certainly not in dental surgery. On the right-hand side there, I've got an Ozotop unit. This is something that I've been using for a long, long time, but it's the only TGA Class 2B product which generates ozone gas. It's like the Helozone if ever you've used that product before. And this is something that we use to dry a tooth after we do root canal preparation. It's not for the disinfection stage, it's just we use it to dry the tooth. But we can use it in peduncle abscesses, in pockets, pericarditis. After a tooth prep, we can use it to dry to basically reduce the bacteria numbers in the prep. A very, very nice product that's not available at the moment, but hopefully there will be something like that again that people can get. So on the central disinfection unit on the left there, that is what we use now. It generates 4 parts per million. And we use that, as I said, to flush the chairs in the morning. But we also will put it into the bottle for the chair so that we can treat our perio patients. We put it into the laser when we're doing laser-assisted periodontal therapy. On the right-hand side is the Kono infection control tap, and that generates about 1 part per million. And that, even with sub parts per million, that is enough to have an effect that reduce the bacteria numbers. So they're very, very nice products, with one which we have in the stereo area and the other, the kit tap, which we have in our room. And we do a preoperative rinse with the ozone. We get the patients to rinse for about 30 seconds. With COVID, you would have known that the recommendation is to use iodine or hydrogen peroxide or chlorhexidine. Wouldn't recommend chlorhexidine, too many problems with that, or ozone. And this is really there to decrease the bacterial, the viral loads, and to minimize the aerosols that are being generated. So this is very protective for the dental practitioners themselves. If the patient's coming in, they're rinsing with the ozone and they don't then generate aerosols which have so much bacteria in it, that is good for us. So these are a couple of the ozone sprays. So you can see the Biosure one on the left-hand side and a newer product on the right-hand side, that's the Ozoneated Pro. That uses a slightly different diamond electrolytic process, which can make the ozone as you press the button. So it's on the fly, as opposed to the Biosure product, which you press the button and it takes 2 minutes to generate the ozone. But both of these are portable and very good for practitioners that perhaps work at multiple practices or they're traveling between places or need something that's portable. So that's it. Those are nice products. So here, this is one of the products that we use, the EMS airflow. We do guided biofilm therapy. So what we do is we apply a dye onto the teeth and we rinse that off with the ozonated water from the unit, and it leaves this either pink or this blue biofilm. And the pink is fairly new, less than 24 hours, and the blue is over 24 hours. So you can see with the combination of warm water spray and the erythritol powder, we are removing all of that biofilm. If you have a look right now, the light blue, that's showing that there's acidic biofilm being produced. So we know that with the ozone, we're disrupting the biofilm. We can reduce things like Staph aureus, but we're also reducing Strep mutans and other bacteria which are going to cause problems in the mouth. This is again the EMS airflow device, but this is with a perio-flow tip. So that's a sub-gingival tip, which we use for 5 to 9 millimeters. And we know ozone is going to kill the bacteria that's there, fungus, kills amoeba, nematodes, it suppresses P. gingivalis regrowth. And then you also have these 14 millimeter particles of erythritol, which will not damage the cementive surface. This is the Photona Lightwalker laser that I use. Here we're generating shock waves at about 40 times a second. You have these explosions that happen underneath the surface there. And so that really circulates the ozone around. It helps to improve the curing process of the ozone. We are removing the epithelial layer of the gums and also the smear layer from the tooth or the biofilm that's on these implants. And so we can then have a reattachment and periodontal regeneration when you do it. These are cases where we use a home ozone tumbler. So this is a product that the patient's able to buy and take home. You can see on the left-hand side these clusters, which means that they're very, very high concentrations of spirochetes. And spirochetes are one of the very bad bacteria. Things like Treponema denticola is a spirochete. And you can see from on the right-hand side, from rinsing for 3 months, this was during COVID, and I wasn't able to give the patient clean. There's still spirochetes there, but much, much reduced. And so after COVID, we managed to get the patient back in and doing them better. This is a patient that came to us, referred to us by a periodontist, and was told that they're ready for the implant. But we can see quite a number of spirochetes on the left-hand side. It's a high bacterial load in 2 months of rinsing, and you can see the bacterial load is much less. There's no detectable spirochetes there. So we're quite happy at this point to say, okay, well, I think you're ready for the implant placement now. But this is how our practice has modified, and we are treating these patients differently because we now are able to look at the biofilm under the microscope. So here, this is a severe periodontal infection, right? So I'll start it moving, and you can see these are spirochetes and amoeba. Amoebas are the unicellular organisms that move around. So this is the case where we would probably decide, I think amoxicillin and metronidazole might be beneficial as an antiparasitic. We might do monthly guided biofilm therapy until we can drop these numbers down, and the patient will continue to use the home ozone therapy unit and continue with them twice a day. And that's where we can start to see that improvement in health and less bleeding and healthier gum. And this is a Biosure product for the space sanitizer system. And we use this in a separate business to the dental. This is a light therapy bed, which we maintain by using the triple S, and that allows the surfaces to be bacteria free. And that Michael has some research on use with COVID as well. So it could be very, very helpful. As I said, even in the gaseous form, it can be antiviral, antibacterial. So this is one of my favorite quotes. I think Maya Angelou says it best: do the best you can until you know better. Then when you know better, do better. And I think once we know that this is something that's available for us, is something that we can use to reduce the biofilm, to reduce the risk to our patients when we treat them, because biofilm, as I said, biofilm is a universal problem, then we should try and do that. And I think this is a pretty simple way that I don't have to think too much about, what I do in the practice. We've got a protocol which just eliminates the biofilm. Certainly within the dental water lines, we can use the ozone sprays to clean down surfaces, to disinfect surfaces after we've cleaned them, things like that. So thank you very much. If any of you want to contact me, you can use the email or the office. I hope you can come and visit sometime.
Thank you so much, Jason. I love that slide there. It's the only dental practice in the world where I've taken my clothes off and hopped.
Well, actually, there's a couple around the world now. Tisha Mabella has his in Auckland, New Zealand. My friend Kinga in Krakow, she has one as well. So yeah, and my friend Hanny my friend Hanny and Susan also in Queensland have them. So there's a few around. If you
let me repeat, it's the only one I've taken my clothes off. Let's say I've never been tempted until I got to your practice, and it was all very disconcerting as I was hopping onto the red bed going, never done this before. So sorry, I just can't help myself when I see an opportunity for humour. Michael, thank you so much. Jason, absolutely thank you so much. So gentlemen who've presented this evening, thank you very much, who's given up their time on a Tuesday evening. Thanks for listening to coming to another episode of Grow My Dental Practice. You will receive a recording of this. Remember to hit subscribe whenever you're on a platform using. You can go to growmydentalpractice.com. And if you enjoyed what you're hearing, give it a 5-star review. Let more people know about it. Can I just mention, in about 3 weeks' time, I will be in Adelaide presenting at the Kooyonga Golf Club on a Wednesday evening with Dr. Michael Cernick. Adelaide people are in for a real treat. I'll try and take along some of our ozonated products. For those of you who are stuck interstate and have to work, I'm so sorry, because it's quite a treat. A, to go to the golf club, and B, to listen to Michael Cernick. God, he's a professor. He's not a professor. I just made him one with a slip of the tongue. Tom, thank you for getting up at 4 a.m. in Kentucky. You may now go back and get some more sleep. I'll see you all here next week. And Jason, Michael, thank you for your time, and we'll see you next time.
Thank you all. Thanks, guys.
Thank you all.
I think that was worth it for you, Tom.
Yeah, absolutely. Absolutely. Thank you.